Hello class, welcome to our video. Today we will discuss the cranial nerve 11. The cranial nerve 11 is also referred as the spinal accessory nerve. Traditionally, the accessory nerve is divided into spinal and cranial parts. Here are two pictures showing the basal and ventral view of cranial nerve 11. Class, is this nerve motor or sensory? It is obviously motor, a somatic motor to be exact. The nucleus ambiguus is a group of large neurons situated deep in the medullary reticular formation. The nucleus ambiguus contains the cell bodies of nerves that innervate the muscles of the soft palate, pharynx, and larynx, which are strongly associated with speech and swallowing. It's a region of historically disparate cells located just dorsal to the inferior olivary nucleus in the lateral portion of the upper medulla. The course of the accessory nerve originates in the upper spinal cord, not the brainstem, then passes through the foramen magnum and runs along the side of the vagal nerve. Then it descends through the jugular foramen, then it runs backward near the jugular vein, descends to the upper sternocleidomastoid, and finally proceeds to the posterior triangle of the neck to the trapezius. The spinal accessory nerve innervates two muscles, the sternocleidomastoid and the trapezius. The sternocleidomastoid muscle is responsible for lateral flexion and rotation of the neck when acting unilaterally, meaning it lets you rotate the head to the opposite side. It is also responsible for extension of the neck when acting bilaterally, meaning it lets you bend the head toward the chest. It is located in the side of the neck and extends from the thorax to the base of the skull behind the ear. It allows the head to turn and lift the chin up and down.
The trapezius muscle elevates, depresses, rotates, and retracts the scapula, or shoulder blade. It is the wide, flat, superficial muscle that covers most of the upper back and the posterior of the neck. It is used to tilt and turn the head and neck, shrug, steady the shoulders, twist the arms, and help raise the arm above the shoulder. Assessing cranial nerve 11.
This nerve supplies the sternocleidomastoid and trapezius muscles. So for an assessment, a patient would need to rotate the head away from one side to another and would tilt the head forward, contracting the sternocleidomastoid muscle. A patient would also flex the neck by both sternocleidomastoid muscles. And lastly, elevate the shoulders and draw the head back so the face is upward by the trapezius muscles.
But what happens when there is damage to the cranial nerve 11? If there is unilateral damage,
it can cause paralysis of the sternocleidomastoid muscle and upper two-thirds of the trapezius.
This will cause difficulty with turning the head to the opposite side of the damage. It may also cause the shoulder to hang, scapula to droop downward, and the arm to not raise above 90 degrees. If there is bilateral damage,
it would leave the patient unable to hold up his or her head due to sternocleidomastoid paralysis.
Injury to the spinal accessory nerve can also cause spinal accessory nerve palsy, or iatrogenic nerve palsy.
It results from absence function of the sternocleidomastoid muscle and the upper portion of the trapezius muscle.
Lesion of the accessory nerve results in difficulty swallowing and speech, including the inability to raise shoulders and turning the head. Well, this is the end of our video, so thank you so much for watching.